Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. All right, got Josh from Alert Medic 1. Welcome, Josh. I sent you a couple comments on, because you and I usually end up talking about cardiac arrest. I did some posts a while back on epinephrine, and a lot of people were on Team Epi. So I wanted to read these comments to you, talk a little bit about it, and then we'll go to the Narcan thing.
Cool.
So I had a post that with some evidence-based medicine, some links to studies about how epinephrine is associated with, yes, better ROSC, but overall worse outcomes, specifically worse neurologic outcomes. In essence, I was making the case that, yes, you may have gotten ROSC when you gave those 9 epis in a code, but you have essentially either made a non-viable patient that's going to die anyway, or you have become a vegetable farmer. So I put, here is your reminder that epinephrine and cardiac arrest is associated with more ROSC and absolutely dreadful neurologic outcomes. Somebody commented and said, it's also associated with not dying. Hope this helps. Well, and then I had a follow-up post about how in 1903, a surgeon pioneered using adrenaline in cardiac arrest resuscitation. They cut a dog's head off, and they were able to keep the dog alive for 10 hours with repeated doses of adrenaline. So somebody, and both of these commenters were medical students, I must add, but he said, I don't understand. So the dog was alive. So epinephrine clearly has benefit. This supports epi. Why is this so hard for people to get? Josh, let's say you.
Okay. So, just off the bat, and I know Mike has said this many times, we've talked about it many times on Alert Medic 1, just because a certain intervention has certain outcomes, whether positive or negative, does not frame everything we do with it. We have to look at the whole picture. And these papers, and it's specifically the Paramedic 2 trial, if anyone wants to look at it, it's Paramedic 2, finds that while, we get ROSC, great. Okay, cool. But ROSC means nothing, flat out nothing, if the patient doesn't survive to discharge.
Well, you can't have survival without ROSC, Josh. You can't say that.
Chicken before the egg before the chicken.
Yeah.
The thing is that, yes, we can pat ourselves on the back for doing a great job in getting ROSC, but in the end, if there's no meaningful outcome, it's not fruitless. Okay, I'm not gonna say it's fruitless, but we need to focus on the things that are actually going to save our patients. And I say that with a little bit of a I don't know, gasp, or with hesitation, because we do a lot of sustaining of life. The whole saving of life it maybe is a misnomer within our profession. We do a lot of sustaining, but saving, this is one of those times where you can save a life. It is a highly deadly disease process, cardiac arrest. And if we can get this patient to walk out of the hospital and have a meaningful life afterwards with their family, that is a save. Okay. But if we just get them, halfway, we never, fully go through and get the touchdown and run through the end zone, whatever you want to, whatever analogy you want to use, what does it mean? Honestly, and if we're using something that drives the initial part, but now, so say, let's use a football analogy. We get into the red zone with ROSC, okay? And
what's
trying
the
to
red zone? There's some people listening who are thinking
okay, so the red zone, real quick, it's within the 20-yard line, okay? 20 yards to the end zone, that's the red zone. And we're in this realm where we're like, okay, cool, we can get a save here, or we can get a touchdown. Save equals touchdown. But we used some trick play to get there. We'll call epi the trick. And that trick play backfires. And now we go to do that and we get knocked back to like the 35-yard line, and then we get knocked back farther, or the epi is the foul in the red zone and it knocks us out, and we don't get that touchdown because we've pushed ourselves further back. And what we should be doing is looking at how to use all the tools appropriately. And does it mean we give epi a different route? There's talk of IM epi out there in cardiac arrest that has some kind of drive towards ROSC and neuro intact outcomes. Do we detract how much epi we're giving? As Maryland went with VF and VTAC. We only give one epi now. That's it. Done. Early on in the arrest. No more.
I'm not opposed to that because it is. I know we're kind of splitting hairs here. Epi does have a ROSC benefit, that's for sure. You do want ROSC cardiac arrest. Duh. We could talk about meaningful ROSC, not meaningful ROSC. I do think epi has a role. I am not opposed to the one shot of epi. Not at all. Yeah, I think I love that Maryland had the cojones to buck the AHA and go to that.
Yep. I mean, it's in one portion. We still have it in PEA and asystole.
Mm-hmm.
But, we have to pay attention to what is actually going to benefit our patient. That's all of our care should, whether it's aggressive, not aggressive, basic, advanced, meds, electrical therapy, whatever it is, should only be for patient benefit, not for driving numbers. And that's what epi does in this case. It drives numbers of ROSC, but it means shit after that. And if my patient's not going to walk out of the hospital after I got ROSC, I'm going to say it's a little bit of a hit to the confidence. You're like, man, I did all that work and they didn't survive.
It doesn't mean shit. I agree with what you said because you took it a little further. I even wrote it down. I said, you're going as far to say that it backfires. I agree with you because of the worst neuro outcomes.
Yeah.
Like, let's say I get a call and it says, hey, dad coded, the paramedics took him to the hospital. And I ask what happened. And my brother says, oh, they did CPR. And, they were there for they did CPR for a couple minutes. They got a pulse back. I'm like, oh, okay. Or they shocked him. I'm like, all right, not good. But then if they say, oh, yeah, they were on scene for like 30 minutes and they pushed a bunch of drugs, it'd be like, he's going to have bad neuro outcome because
it's very true, and this just kind of dawned on me. You brought up how the commenters are medical students, and I'm not going to knock on docs. Okay. That's not what I'm about to do. The commenters are likely new to medicine. And I had this conversation actually with a rookie last night on the way back from Fairfax, of all places. I had to go all the way down there. And I think maybe part of this is they don't understand that side of medicine that, Mike, you and I have seen a lot in my 18 years, your 23 years of doing this, of the patient that, they got ROSC'd. They made it through the ICU. They're now at a skilled nursing facility and they stare at a wall and they can't talk to their family.
Oh, yeah.
They gain more comorbidities, more issues. We're taking to the hospital for, UTIs, sepsis, bed sores, pneumonia, a laundry list of things. And that patient is never the same prior to that event.
No.
And and you guys talked about it this morning, not this morning, but when I listened this morning, the moral injury that comes from that, treating those patients and having to take them to the hospital, and it's fruitless. Nothing's going to change that they don't have brain activity in the way they did before. And then to tie this all back, if we can reduce the chance of that with simply not giving one medication a lot or however many times, why not? Why not reduce that?
Yeah, I agree with you. Because that's the way we've always done it. And the AHA says happy every 3 to 5 minutes.
Yeah. And, when we also didn't look at the physiology of it, I'm not the greatest at physiology. Moose is that guy from us. And But you have like this endogenous and exogenous catecholamine release with all this epi and the cardiac arrest process, and it can have some detrimental effects. So like, why we already are creating a lot going on with the cardiac arrest process and CPR and everything? Why add to an overabundance
Well,
possibly?
yes, I like you, I am not a physiologist. Moose is freaking, I mean, compared to me, Moose is genius with
Yes,
nitty-gritty physiology. And
agreed.
he really is. He's brilliant. But I am a good bullshit detector, and I do recognize things that we do that contradict and don't make sense. And I think we've talked about this before.
Yeah.
You guys give Esmolol for VFib, right?
Yep.
For refractory VFib. And the thought behind that is that in these VFib states, you get this massive catecholamine surge that makes the heart quiver and
Hmm.
fibrillate. And the thought is that if they're not responding to defibrillation, they're having this catecholamine surge, you give them Esmolol to block that sympathetic response and reduce the catecholamine surge.
Correct.
If we're worried about a catecholamine surge, why the hell are we pushing the ultimate pharmacologic catecholamine every 3 to 5 minutes?
Yeah. No, I agree. And I I don't have papers in front of me right now. I don't have data to support anything about what I'm about to say, but um, I'm not trying to toot Maryland's horn, but since 2017 we maxed out at 4 in our um, algorithm. And granted, like we just said, we went to 1 during VFib. We're at 4 during PEA and asystole. Once we hit 4, that's it. We can give another 2 if they rearrest after ROSC, but there's other places, and I'm not trying to call PA out.
Say it.
PA gives it and gives it and gives it, and they give, as you love to say, gobs and gallons
They did
of
they did
epi.
they did add in that they, now you can't do anything about it, but they did add a footnote in that more than 5 doses is likely to be of no
Okay,
benefit. But it doesn't
good.
say you can stop. So yes, for now. Now
Yeah.
we have a great medical director in Pennsylvania. I listened to your podcast with Chismar. Did I say
Yep.
his name correctly?
Yep.
That was a great podcast, by the way. If people haven't listened to that, I mean, I wanted to like hug that guy after I got done listening to your podcast.
Yeah.
And we're lucky to have Dr. Bledsoe in Pennsylvania. He's
Hmm.
progressive. He's a medic. But the Pennsylvania politics is, he's not an army of one. He can't just, whip his pen.
Yeah.
There is by law legislated in the EMS Act, things have to go through a committee. And there are, now this did not come from Dr. Bledsoe. He did not tell me this. This came from another medical director who I'm not going to mention his name. He's awesome. He said that there are a lot of fossilized,
Hmm.
old, dead weight on that MAC committee that are holding back progress. But he said, he's like, rest assured that there's a lot of younger people coming up
Yeah.
and
And
getting
and
things
we see
changed.
that too in Maryland. But to kind of tie back into like why I'm bringing up Maryland, why I'm bringing up PA, insinuating other states that don't have restrictions on their epi or agencies that don't have restrictions on their epi, I'd say probably anecdotally, the ones that have restrictions on how much epi they're giving are seeing more ROSC and and likely more neurointact outcomes. Um, and I know for me, I saw at least a notable jump in ROSC and neurointact post 2017.
So do you find that you're working less codes, or that you're more likely to terminate a code that's not having a good outcome? Or are you doing the old school stuff of like, all right, we're giving our 19th epi, you better transport them? Are you
No,
guys still doing that?
no. Yesterday, I had a code that was PEA the whole time. So I'll asystole into PEA. We gave our 4. We had some other issues that you and I have talked about offline.
Mm-hmm.
But at 30 minutes, with the use of POCUS, we terminated. But
Good
we
deal. I mean, that's
definitely
for the patient, but
definitely terminate when it's indicated. Um, it's just we're putting ourselves at risk of transporting that patient. We're putting ourselves at a detriment to keep on working, endlessly on scene and giving all these meds. I was just thinking, like, I can't even remember how many meds we used, how many epis we used to carry before the change, but it just seems like the whole drug box, like you had an epi box essentially,
Yeah.
just
Yeah.
to give and give and give and give and give.
I,
So
I have stopped. If I get to the point where it's one of these patients that, and I pronounce a lot of them, I don't want people to think that I am working, transporting an asystole code that has been an asystole or a slow wide PEA. But there are those patients that, they're dead.
yeah,
They're in a PEA, a narrow complex PEA at a rate of 80, and they have a decent end title. Now, this is why I want POCUS in
yep,
Pennsylvania, because I want to know, is this patient dead as shit because they have fixed and dilated pupils, they've had no response, or does this, as we're going to talk about with the Narcan paper, a super low flow state?
yeah,
There are those patients that I just, this is me personally, other medics may feel differently, but if I've gotten no response, but you've got an end title of like 60 and you're in a PEA at a reasonable rate,
yep,
I ethically feel like I've got to transport you.
yeah. I mean,
And as
for
tool
us,
baggage, as nerdy as it says, because I know I have been critical of Balpocus, I've changed my mind on it, but I do feel like I've got to take this person to somebody who can tell whether this person is actually dead or not with an
no,
ultrasound probe.
you're 100% correct. And in fact, it's in our protocol. If they have an end title over 15 and they're in PEA, transport.
But what I was getting to is I am not one of these people who transports them now and gives like the 17th epi, like mixing it with epi 1-to-1 and diluting it. I just don't do it. I just stop.
Yeah,
And if the doc, it has happened where the doc was like, your last epi was 15 minutes ago. It's like, yeah, I ran out.
yeah, and that talks to something we all talk about all the time. It's just basically a clinical thought, clinical decision making, gestalt.
Mm-hmm.
Like we are bringing in years of experience with these patients, knowing that these interventions we're going to do don't mean anything, and all you're doing is making them worse, most likely. Let's be honest,
Mm-hmm.
and yeah, you know, the epi question. I think ultimately, and I'm sure people are gonna, have a curmudgeon feeling about this. Epi's gonna go away
Oh,
in
come the TikTok comments. I had 4 patients this week who got epi and they walked out of the hospital.
and I say to those guys and girls, hey, look, it happens. Rock on with your bad self. Like that happens. We can't say that this is a blanket statement that just because you gave epi, all your patients at Rosk are going to have bad neuro outcomes. No, you know, there's so many things at play that we don't know. True downtime, true bystander CPR, true cause. We presume cardiac a lot. I mean, on image trend, it is the the first option, and in parentheses says presumed next to cardiac.
You are that same way in EMS charts,
Yep.
presumed cardiac in the care section. I would be willing to bet that hypoxia is an underappreciated cause of cardiac arrest in the adult.
Yes. Yeah. The obese patient,
Yep.
the bedbound
Yep.
patient. Um, yeah, a positional asphyxia is,
I had one last week.
yeah,
Got him back, GCS of 15 at the hospital.
yeah, and I think as we shine more light, cardiac arrest has gotten a lot of spotlight in the past 6, 8 years. I mean, really big spotlight on it, and I'm really glad it did. Um, Obviously, I'm here talking to Mike about cardiac arrest. I love talking about cardiac arrest. It is like one of my, uh, it's my favorite thing to talk about, honestly, probably in EMS aside from some trauma stuff. And hopefully, we now start looking at the causes of arrest more and being like, hey, how do we tailor our approach to this? And thinking about how we found the patient, their comorbidities, their history, what the family told us, all that stuff, and maybe targeting some stuff a little bit more. Like if we think it's a hypoxic arrest, should we be really focusing on ventilations and our oxygenation of the patient, getting that number back up, stuff like that. So I'm excited to see where it goes. It's just, where cardiac arrest is going to go, I think, is going to be less epi in most cases, more directional care in cardiac arrest, determining why. I know we've always talked about H's and T's, but actually like looking at it from the start and doing certain things earlier. We're starting to talk about it in trauma arrest. Trauma arrest is finally getting the attention it needs. I know if you guys listen to Mike loves himself some changes to traumatic arrest.
I do.
He does. And we've talked about it with Dr. Kasim Kasim, and you're going to see things like compressions aren't the first thing you do. You got to reverse some causes. Maybe in your respiratory or hypoxic arrest, we really focus on getting, 2-hand seal on the BVM. No DSAT from the beginning, getting lots of O's in this patient along with compressions.
Yeah.
And what we're about to touch on, maybe bring back Narcan in arrests. And I know everyone's going, they didn't say it. They've poo-pooed this thing all along. They've said no Narcan. And we're not saying yes, but we're entertaining the idea that has been brought up via 2 papers, one out of Cali that looked at 3 EMS agencies. And it's retrospective. These are not prospective studies.
I missed. Yes, you're correct.
Yeah. So, and then there's one that looked at Narcan in non-shockable cardiac arrest. If you guys want to see a really quick, dirty breakdown of both papers, Army EM Doc, Steve Shower, posted these the past couple days. So to give everyone like a background on this, if you're not aware, most of the literature and teaching lately has been that we don't give Narcan in cardiac arrest. Give it during ROSC if you think it's going to be beneficial, but during cardiac arrest, the physiological action of Narcan doesn't translate to fixing the cardiac arrest. They're not lacking Narcan. They're lacking oxygen because the opiate that was taken created a period of not breathing or breathing very slow that created hypoxia, and then it's a hypoxia-induced arrest. So if we reverse the lack of oxygen, compress, get stuff moving around, start remetabolizing, getting metabolism going, feeding the brain, feeding the heart, feeding everything, perfusing, in theory, we should be able to ROSC. And that Narcan, working on an opiate site in the brain, doesn't contribute to that. So that's the background on why we walked away from Narcan, when I know as an EMT, even as a early or young medic, and Mike, I'm sure you gave plenty of it during arrest when we thought,
yeah, shit ton.
Yeah, this was the D50 Narcan.
I shouldn't say
cocktail.
A shit ton, but
enough
in every code that maybe an opiate was administered. Yeah.
Yes. Yep. It was normal. And then we looked at the physiology and we looked at like, is this really going to work? And a lot of people came up with, we don't think it's going to work. So I know I've adopted the practice of not giving it during cardiac arrest. Mike, I'm sure you have.
Yeah, we don't. It's not in the protocol.
Yeah. And yeah, there's another thing. It was taken out of protocols. So Cali paper. Cali paper looks at 3 agencies in Northern California. It's Sacramento City, San Francisco, and Yolo County.
Yeah,
Yolo County. And it was a huge time range grab. 2023 all the way back to do you have it up?
2015 to 2023.
Yeah, so 8 years of data.
Yeah, and I'm looking 8,195 patients.
Yep. And then of that, like it's a little like almost
1165.
Yeah, 1165 received Narcan. And then they break that down even more, where it's like 800 to 900 of them were suspected opiate or overdose related, and then like another 200 to 300 were not associated, were not suspected overdose. And they found that there is a uh, statistically significant increase in ROSC and almost a statistically significant increase in survival to discharge with neurotact. And so I'm looking at this. Mike's looking at this. I pitched this to Cody too, and he's looking at it. One thing is that most of these patients were in non-shockable rhythms. So now we're diving into.
That tells me PEA. I have my doubts that these patients were asystolic.
Yes, so there's probably a high prevalence of PEA.
Which brings us to your point.
Yes. So we're not going to dive into a whole lot of this, but we're going to put it in this perspective of Narcan use in cardiac arrest. So if you paid attention to our Instagram over the past month, if you paid attention to some of FOMED and talk about POCUS, there's this thing called pseudo PEA. And pseudo PEA is essentially someone that we find that when we put them on the monitor and we see a rhythm that is organized, slow, fast, narrow, wide, whatever it is, but it's organized, and we don't palpate, we can't feel a palpable pulse, we call it PEA. Must be PEA. But if we factor in POCUS or Doppler, is another way to do this, and we find that they actually do have a pulse that's just so, and the pressure is so low that we can't palpate it, even in the carotid femoral, it's pseudo PEA, because they're in this they're walking a tightrope of life, because they could easily fall off into true pulselessness, or they could fall into the other side of gaining a pulse because they're in a low flow state right now, and if we do things to bring that pressure up, then we have a pulse. So are these patients in a pseudo PEA and they actually have an ability to circulate the Narcan, have it work on the opiate sites, which then locks out the opiate, which in turn stops it from working? So now if we focus on oxygenation and like getting those O's back up and getting, ROSC and survival to discharge, is that what's going on here? But that wasn't studied, and I'm not knocking the study for that. There are holes in both studies, given. But were they in a true state of arrest, or were they in a low flow state? And we just didn't know. The providers didn't know it. And I don't knock the providers. If they don't have the tools to figure that out, and the only tool to figure it out, it's going to be straight honest, in EMS is going to be Doppler or POCUS.
Oh, 100%.
We're not dropping art lines.
I've had these patients where I'm thinking, I bet you that this patient is alive, but I can't palpate a pulse. They have a rhythm. That's PEA. That's, I don't have POCUS. That's PEA. And they get the chest compressions.
Yeah.
It does, it does make me wonder. So going back to the positional asphyxia, my guy a couple weeks ago or last week was big fat guy, rolled out of bed in a tiny little bedroom. He got wedged between the wall and the bed, came in as a lift, an ALS fall. The notes were bullshit. I was like, this is a lift assist. Why are they even sending me? But I happened to already be in the car and I was 2 minutes away. So I pulled up to his house. It's in the middle of the night, no traffic. Doesn't matter. Why am I telling all this? And he's wedged between the wall and the bed, and he's big and he's blue. And I'm like, he is dead. And the lady was like, well, he was just talking. So he was huge and it was just me on scene. So I was able to roll him over a little bit and get him on his side, but he was still wedged between the wall and the bed. I couldn't palpate any pulses. I was like, I got to do chest compressions, but I couldn't roll him all the way over because of how cramped the room was.
Yeah.
So I was able to turn his head a little bit and reposition his airway, and he took a couple agonal breaths, and then I bagged him, and he woke up. And I thought the same thing. This guy was never in arrest. He was in a low flow state due to profound hypoxia, and we would have needlessly done chest compressions on him.
Yeah. And, good on you, Mike. Not trying to, pump up any ego or, blow smoke up your ass or anything like that. Good on you, because there's plenty of people that are like, I can't position this guy. I gotta wait for the EMS crew to show up, and that would have put him farther down the rabbit hole. So
Mhm.
like, we gotta. This just speaks to, we gotta do whatever we can to try and benefit the patient, and if it's just that little crack of opening between the wall and the guy's face, get some breaths in, some natural passive O2 flowing in, and then able to get some kind of seal and give some oxygen. And that's all, that's what the body is starving for. That's why there's a, I don't want to say it's famous. There's a video of a, I think, Brazilian surfer, female surfer, pro, and she goes under the water due to a wave. They pull her out. She's drowned. She's in arrest. They get the BVM on her face, and like, she is up within, I think, within minutes of the start of the whole thing. That is not because of the compressions. That's because of the oxygen.
Yeah.
And if we just give the body what it's starving for, this guy's probably got a ton of comorbidities, but his arrest was not cardiac. His arrest was just lack of oxygen.
Presumed cardiac if it was a code.
It probably would have been, to be quite honest,
Yeah. But anyway, back to the low flow. So yes, some of these patients are probably not in cardiac arrest, and you're spot on. You're not going to know that.
Yep.
I say even Doppler is tricky.
Agreed.
Because we'll fly these patients with these acute arterial occlusions, and the sending ER is like, yeah, we couldn't get anything with the Doppler, and I believe them. I'm not saying they couldn't. They missed it. Yeah, like absolutely. And then you'll see that they still had. We'll read the reports when we do our follow up, and you'll see that they still had some flow.
Yeah.
So I don't think Doppler's perfect. Ultrasound's not perfect either.
Yeah.
But it's ultrasound's the way to go.
Yeah, and that's ultrasound, and if it ever comes to EMS, which I don't think it's going to come to the regular paramedic, it might come to some kind of advanced practice medic or critical care medic in the 911 setting. Huh?
A paramedic practitioner?
Oh God. Artline is the other one, but that's way more involved than taking a probe out and putting some jelly on the neck or the chest.
I don't know, because I've taken some freaking patients where we're looking at this flat ass dampened waveform, and we're like, are they alive? I don't know if they're alive or not.
Yeah, you would know better than I. I mean, I've never.
I think
or monitored.
I think I'm not a physician, but I think from my experience, ultrasound wins in the rock paper scissors game.
Yeah,
of detecting heart activity.
And I want to just put this out there, like, whatever your agency is doing is what you have to keep on doing.
Yes.
Okay. If your agency is doing POCUS, implement POCUS. If they're not, then you just need to understand that, like, hey, some of these PEA patients, they may be, but you don't know. And you have to treat them as your protocol and as your SOGs, SOPs, CPGs, whatever you want to acronym you want to use today. Whatever they say to do is what you got to do. Transport should be it is a treatment, but you need to use it judiciously. If there are multiple things on scene that are making you think that this is not a viable PEA arrest, then go on with your termination. But if there's something that is just sticking out that just doesn't feel right, a red flag. Mikey and I talked about my PE arrest last summer.
Mm-hmm.
And the dude started in asystole. It was in PEA. And I was like, but this has got to be PE. He dropped dead in front of 20 people and had bystander CPR. There's no way that this is going to be a termination. I got to transport this. Eventually, he went into VFib, 6 times. But, use the clues on scene. Use your gestalt. Use the opinions of the other people on scene. Talk to your fellow crew members, EMTs and paramedics alike. Be like, what do you guys think? You think there's something here that we're not seeing, that we're not figuring out? Should we go down that pathway and treat that possibly if it's indicated and we can do that during arrest? Or, do we transport this patient? Do we terminate this patient? What? This should not be like, something you're doing in a vacuum.
Yeah. Should we be pushing Narcan in this patient?
Yeah. Hey, you know, I'm sure I was talking to Cody. This would be a really easy thing to do a prospective study on. I feel like.
Oh, 100%.
I was saying like agency 1, you give Narcan to everyone, every cardiac arrest. Doesn't matter the etiology, just give Narcan. Agency 2, you give Narcan to overdose associated cardiac arrests. Agency 3, you give no Narcan.
Yeah.
And maybe somehow focus in some POCUS, but that's maybe a little bit too niche within that study. But like this could be, it's very easy perspective. There's no extra money. All it is data tracking.
Totally. 100%. And there's not really an ethical dilemma right now because Narcan's not recommended in cardiac arrest.
Correct.
So nobody can make the argument, well, you're withholding care from somebody.
Exactly.
That's what they're making with the epinephrine thing. Like, well, can't really study it because you're withholding that potentially life-saving intervention.
Yep.
So looking at this second case makes me think even more that you are right, that these might have been low flow states that were, and again, I'm not saying this negatively on the paramedics because I'd do the exact same thing if I were them without a POCUS probe, but I think these may have been misidentified as being in cardiac arrest when they were a low flow state. The second study, it was a secondary analysis of patients who got Narcan before EMS arrived. Am I looking at that correctly?
I'd have to pull up. I don't.
Eligible patients had non-traumatic out-of-hospital cardiac arrest. Oh, they received. I'm sorry. I was kind of right. Actually, I was not. They received Narcan by EMS or law enforcement prior to IV or IO access.
So they got intranasal. Okay.
Yes.
Or IM. One of the two.
Yeah.
Probably intranasal.
Probably intranasal. And if it was the police, it was probably 3 gallons of nasal Narcan. You know, I made a post just being funny about that. It was a drowning scene in Baywatch where David Hasselhoff is telling the guy, like, yo, cough out that water, cough out that water. Yeah. And I said what it's like pulling up to an altered mental status call when the police have given 14 milliliters per kilogram of nasal Narcan. And this guy, he's a douchebag. He's a medical director in my area. He commented, first off, it's not given in milliliters. It's given in milligrams. No shit. So I wrote back because I normally don't engage in the comments. I was like, yes, nuance is very hard for some people. I guess they didn't teach that in medical school. And then I'm going way down a rabbit hole. Somebody sent me a very, very snarky email to his staff. And I agreed with what he wrote because it was, hey, your charts are written at a 3rd grade level. Can you try to be cognizant of grammar and syntax? But it was really shittily written. And the last sentence, he used a double negative. I'm sure accidentally, but I was like, you just sent this scathing email to your staff about using proper grammar, and then you end it with I don't have no ability to. But anyway, yes. So this was so they received Narcan by EMS or police prior to the IV or IO access. So what that tells me from experience is you roll up on scene, you find an unconscious person laying on a street corner or on their couch, and they right off the bat get nasal Narcan.
Mm-hmm.
So then we start the whole chest compression thing. Was their heart putting out output at the time? That's the question.
Yeah. And this kind of brings into this talk. I don't think it's being had a whole lot, but it has been suggested in some of the stuff on pseudo PEA. If you have POCUS, I know it takes a little extra time, but they're saying should you try and get your first good pulse check with POCUS? I know that opens a bag of worms. So if you're listening to me, this is just an idea.
We're just spitballing ideas. We're not saying to
Yeah.
do this. We're just talking out loud because
Yeah.
that's what people do.
Yeah, exactly. And honestly, in the end, like if you can't palpate a pulse, doing compressions is the kind of the right thing to do in the end. Not kind of, it is.
Yes,
Because
because we're talking about this, and I could see me going to a call. Patient has no pulse, they're not breathing, and my student goes, "Well, they could be in a low flow state." I'm like, "No, dumbass, start CPR." So,
and the problem is that yes, they're in a low flow state possibly.
yeah,
But guess what's going to help it for the moment? Us doing compressions because
yeah,
we're creating a much higher flow state. It's not like, anything drastic, but it's something. And to add to this, in my agency, when we do find carotid flow, um, but have no palpable pulses still, we continue compressions and, in conjunction, start setting up our levo drip and, getting that going. And then once we do have palpable pressure pulses, that's when we call ROSC. They're not in ROSC just because they have flow. If they don't have palpable pressure or pulses, they don't have the perfusion ability at the current time. So we need to support it, and support is compressions, levo or epi drip, stuff like that. Get that pressure up, and then perfuse the rest of the body. But don't take this as how you should practice. Take it as an idea, factor it into your clinical decision. Like it's not the end all be all. It is this is a possibility. If it is happening, what do I do to support it and make it not a low flow state anymore?
mm-hmm.
And that is whatever you need to do. If it's not cardiac arrest and you think, well, actually, no, because you're going to assume this is cardiac arrest because they have no pulse. Compressions, and then start working the problem. Figuring out what's going on, how to fix it, how to go from there, and work on it.
Yeah,
And
yeah,
and also, I know this ties back to the other. An initial, maybe one epi might be what they need to get that thing up. They might need that little bit of pressure early, quickly, and then gets it up. But the continued drenching of the patient in epi
yes,
is not
yes,
the go or the thing.
yes. Yeah, totally agree with you. So bringing this whole, I think, kind of, we have, I think, brought this weave in with the Narcan thing in cardiac arrest. Dr. Mohammed Hagmed, he's a ER physician and medical director in Western Pennsylvania. He's one of the really good ones in Western Pennsylvania.
Mm-hmm.
Oh, damn it, his story expired. He commented on Shower's post and reposted it with his where he put his own 2 cents in.
Yeah.
He's a great guy. He still works a shift as a paramedic a week because he
Wow.
loves being a paramedic. Yeah. He wrote that was like, yeah, all right, maybe some promise, but you want to give Narcan, give the Narcan, but you have to prioritize the interventions that matter, like
Yes.
compressions, the ventilation if they're hypoxic,
Defibrillation.
yeah, yes.
Those are the things that are going to fix things. It's the
I'm
basic
not
stuff.
opposed to pushing a Narcan.
Yeah, I mean it's simple, it's cheap, it's easy, it's quick.
Yeah, I don't think we should be doing it on every single patient.
Yeah,
Just
I don't, if maybe the other paper does. I know the Cali paper didn't talk about it. If it was IV or IO Narcan that they gave during the arrest, or if it was intranasal. So you kind of hit on that a little bit with the.
well, it wasn't IV in this, but in the Cali study, let me see. I don't know. I don't want to.
I don't think it was. I went through that one completely.
Okay.
But that's something else to think about, how you're giving it. I know there's always been some talk about like sometimes intranasal has more efficacy than IV, which is kind of weird, but
I wonder if that data is also skewed because I used to think before, I thought for years as a medic, why the hell doesn't BLS have Narcan? And then, like, why does a paramedic unit have to respond, start an IV, and we know that a lot of these people, well, everybody snorts it now, but back in the day,
Yeah.
everybody was shooting it. So they had shit veins. And so you'd be poking around for an IV forever trying to get it. Then you would push the Narcan. So I would always think like, this is ridiculous. Why can't BLS just give intramuscular or intranasal IV or Narcan? And luckily the medical community took it even further and said, let's give it to the community. So I wonder if the intranasal has better, I haven't looked at any of the numbers. This is just me speculating.
Yeah, me neither.
If there are better numbers for intranasal because everybody has it and it's being given earlier now, rather than waiting for the paramedics to show up and start an IV and give it IV. I mean, that's a substantial delay.
Yeah, no, you've got a good point. I don't think. I mean, if we're going to look at the time frame on that Cali study, 2015, that might have been right around when Maryland gave Narcan to basics. I think it was definitely in like the 2010s. That's for sure. But don't quote me on that one. Brain's not always clear.
Yeah.
So, but yeah, I mean, once again, me and you taking on controversy and cardiac arrest.
I'm down. I'm about it, man.
Yeah, your first episode with us was taking on dextrose and cardiac arrest.
Yeah. Yeah. I that's going to be a different, because people are going to now, I could see some people saying, well, they're going to put Narcan back in the arrest protocol. They put dextrose back in too. It's no different totally different physiology.
Yeah, that and I know we're kind of like wrapping this up. Just to hit on it real quick.
Take your time.
The physiology is a theory on this, by the way. At least in the Cali paper, their theory, and it's a heavy theory, is that it decreases myocardial depression, which then helps with catecholamine release, which then drives up pulse rate, cardiac output, all this stuff. And it's like, as I said to Cody, we've been using this thing for like 40 years. I feel like we would have figured out by now that it increases catecholamine release.
Yeah.
Or something. And that it doesn't have like this whole singular thing of locking out the opioid receptor. I don't know.
Or does it increase catecholamine release because they've been studying it on people who got Narcan and now they're having a withdrawal-like state and they're now tachycardic, tachypnic, blood pressure goes up because they're feeling like shit. I don't know. All questions to answer. I mean, here's the thing. People don't realize, everybody wants to know the why, which is great.
Mm-hmm.
It's the whole point. That's the whole reason you and I do the podcasts. But you're not always going to know the why. So my dad was a retired neurologist. He had a great career. And I asked him once when everybody was switched, because back in the day, you young paramedics probably don't know this, but seizure patients took Dilantin. They didn't take Keppra. Yep. And Dilantin came with different problems. It was, if you were sick, it could alter your levels. Your dehydration could alter levels. So patients would either have something physiologically going on with them, so they wouldn't have a therapeutic level of Dilantin, and they would have seizures all the time. So they switched over to Keppra. And everybody was now transitioning to Keppra for their seizure maintenance. And I said to my dad, I was like, hey, why is everybody on Keppra now? And he said, well, it works better. And I said, well, yeah. He goes, well, it's not as finicky as Dilantin is, and it tends to work better. I said, yeah, but how's it work? And he said, oh, I don't know. He's like, it just works on seizure activity. It works better. And it's got fewer side effects. He's like, I don't think anybody knows. And I was thinking like, oh God, that's a terrible answer. And wouldn't you know, probably 15 years later, here I am. I'm reading stuff about Keppra as I'm preparing to teach this flight medical provider course. And I was teaching the neuro lecture later that day. So I was researching some stuff and I came across a paper and it was like, they still don't exactly know how Keppra works. And I was like, oh, he wasn't just bullshitting. He was right. But that's the thing. Like in the medical community, some things you just don't know.
Yeah.
You're not going to know the why for now.
And sometimes you may never know the why. And sometimes you might not understand the why. Even when it is there. And it's a constantly changing field. That's why right now I'm looking at these papers like, okay, there's something here. These can't be completely just discarded and thrown in the trash. Like, I know Narcan is not meant for cardiac arrest. Toss out the papers. No, there's something here, and there's definitely some key things that kind of call it out, and hopefully these papers cause a prospective study somewhere in the U.S. that looks at like, hey, like, is this real? Is this just not like 8 years of data that just happens to point in one direction? So that's the perks of a prospective study, that this is better data. But yeah.
Well, this was lovely, Joshua. Thank you for.
Thanks, Mike.
Yeah, let me stop this, and I don't think I'll have this out before Christmas.
Well, that's fine.
So I won't say have a Merry Christmas, but I will say have a Happy New Year, because I should have this out before New Year. All right, let me stop this.